let's get started. So Ashmita is our first presenter, and the posters is involving patients, family, and caregivers in policy for integration through primary healthcare teams. So please feel free to share the poster, and please give us a little bit of a description.
Thank you. Let me just share my screen first. There you go. Can you guys see it?
Yeah, we can see it. Thank you.
Yeah, all right. Good morning, everyone. This is Ashmita Rai, and I'm a research assistant and graduate student at the University of British Columbia. First of all, I would like to thank all my co-authors, including Brenda and Peter, who is with me, and Karine, Darlene, and Nelly for their contribution, and our funders for their in-kind support. The title for my presentation today is Involving Patients, Family, and Caregivers in Policy for Integration Through Primary Healthcare Teams. So improving healthcare services integration for people with 2 or more chronic illnesses is a challenge because they require complex healthcare needs. A team-based approach where 2 or more healthcare providers work together for providing care in the community is often used to meet their needs and improve outcomes for patients, healthcare providers, and health system. Our patient-centered research involving patients, family, caregiver, and policy related to primary healthcare teams is being carried out in 4 provinces in Canada, including BC, Alberta, Ontario, and Quebec. And there are 3 phases in the study. In phase 1, we conducted policy analysis related to primary healthcare teams, and the results showed us that involving family, caregivers, and patients in policymaking was the main focus, but their roles were not identified. Also, it was not clear on how the patient partners are included in applying and evaluating the policies. In phase 2, we studied patient engagement and policy via interviews with patient participants from 3 different provinces except for Quebec. We sought to understand if and how patients are involved or want to be involved in policy activities. These results presented here are from BC. And in phase 3, we seek to provide recommendations for policy change. And for the methods, firstly, we conducted pilot interviews with the help of our patient partners, and who also helped us revise our interview guide. Then we conducted 10 semi-structured interviews with patient participants, both with and without the experience of involvement in policy. The results of the interview indicated that all the participants wanted to be involved in policy planning, implementation, and evaluation, and also advocate for themselves, their family, and friends. They felt empowered when their voices were heard. However, they experienced power differences or competitiveness between the health authorities and patients. Our major findings were the barriers to participation. We found that most people were not aware of the engagement opportunities around policy development, implementation, and evaluation. There was a lack of accessibility to involvement opportunities, such as access to computer or internet facility or transportation services. Similarly, some of the other barriers, such as tokenism, racism, sexism, ageism, and lack of incentive, reimbursement or honoraria to include varied patients or caregivers such as working men and women, youth, and marginalized population were also identified from the interviews. Patients' health condition also played a part in patient participation, where patients may not be well enough to attend those events. All these factors may result in the loss of huge demographic population to patient engagement. Our results have potential to provide a foundation for policy change as per the healthcare needs of this population. A few recommendations on policy change were provided by the participants based on their experiences. They emphasize that patients should be educated and encouraged to voice their needs through active engagement in strategic planning of services and policy activities. And fair and equal opportunities should be provided to include people from different groups, and that there should be a mutual respect for patients' opinions, values, and perspectives. The patient participants also mentioned how difficult it was to participate due to the use of medical jargon. So providing reliable and friendly information is vital to patient engagement. And finally, offering incentives, adequate advertisement of the involvement opportunities may boost the participation. There were some other recommendations for practice change, which includes effective and frequent communication between healthcare providers and patients through patient portals, and inclusion of liaisons such as a trained nurse navigator or a social worker to communicate with healthcare providers. Most of those interviewed wished for shorter wait times and longer appointments with healthcare professionals, and believed it would be a cost-effective method as it would decrease frequent visits and improve the health outcomes. And since we completed the interviews in BC, we will be holding a deliberative dialogue or discussion session with 10 to 15 participants on the 21st or 23rd of October. We will provide the summary of the results thus far to the interested participants for their review. And this online discussion will be used to co-create actions on ways to increase participation in policy. We will be using integrated knowledge translation activity, where we will be conducting national KT activity, that is knowledge translation activity, and which will be organized sometime in February next year. And we will share the results and receive feedbacks and actions from patients, researchers, policymakers, decision makers, and the providers. And we will also share our findings with research team members, collaborators, and all the interested individuals in each of the provinces, nationally and internationally via academic publications like journals and presentations and conferences. And that's the end of my presentation. Thank you for having me on this event. Please feel free to email me for more information on the study. And also, we are openly recruiting 10 to 15 participants for the deliberative dialogue session until the 18th of October. And you can email me if you would like to participate with us. Thanks again.
Thank you, Ashmita. So if anyone has any questions about this project, or even in terms of how to get in touch with Ashmita, please feel free to use the chat function, and Ashmita can respond to any questions that arise there. Thank you very much. So let's move on next to Ivana, who is going to tell us about tertiary mental health treatment during COVID. So please feel free to share your screen, Ivana.
Great. All right. Thanks, John. Just bear with me for 1 minute, everyone, while I pull up my poster. All right. Perfect. Is that visible? Great. All right. So thank you very much for coming, everyone. As John mentioned, my name is Avarna Fernandez. I'm the research coordinator over at the St. Paul's Hospital Eating Disorders Program in Vancouver. So the title of my poster is Lessons Learned in Tertiary Treatment, Patient Experiences of Virtual Care During the COVID-19 Pandemic. So the St. Paul's Hospital Eating Disorders Program provides inpatient and residential care to individuals who are diagnosed with severe eating disorders from across British Columbia as well as the Yukon. And as you all know, in March, COVID hit us quite suddenly and kind of turned all of healthcare kind of on its head. And as a result, all of our care switched from in-person to virtual means. And as a result, our research team developed an experience of care survey to kind of better understand our patients' experiences of our switch to virtual care and ultimately understand not only their experiences, but what's going well and what can be improved and how we can move forward. So our survey kind of had two parts. First and foremost, we had patients rate each type of care that they received, both on satisfaction as well as their perceived benefit of continuing with this type of care virtually post-pandemic. And then we also had an open-ended section where patients could express, the different drawbacks as well as benefits to virtual care and, shed some more light on their experiences. So if you look at the middle of my poster, you'll see a table there. So all of these percentages represent the percentage of patients who rated that specific treatment modality a 4 or a 5 out of 5, 1 being I am not at all satisfied, and 5 being I am extremely satisfied, with a 4 being I am quite a bit satisfied. So as you can see, our ratings are quite varied, but overall we found that individual sessions were rated quite a bit higher than group sessions. And looking at the benefit of continuing, we also see a mix where there were some sessions that patients found were quite beneficial to continue virtually, while others, they much more preferred to resume in-person care. Looking at virtual care related challenges specifically, so this is really just about challenges experienced with using a virtual platform. The majority of our patients didn't encounter any challenges and were quite happy with switching over to Zoom and phone. However, there were some people who experienced, run-of-the-mill technical issues, as well as a bit of a learning curve with first learning how to use Zoom. And there were also some people who expressed a bit of concern over disclosing their private health information over a platform like Zoom. We also asked about, were there any other challenges that you experienced? And by far the most prominent one would just be overall patients feeling a bit of a difficulty feeling connected to the program compared to what they were expecting if they were to receive in-person care, which I think is very understandable. We also had just, people expressing a bit of a struggle to find a balance between engaging in care while at home, while also trying to balance things like childcare and homeschooling, and just trying to find a private space where you can really engage with your practitioner or other patients in the program, and talk about the difficult things that are going on associated with your health condition. And then, of course, I think something we can all relate to is just having a bit of a hard time spending so much time on a screen and just feeling really exhausted at the end of the day. Looking at our qualitative part of our study, where we had patients basically just share any feedback that they had, we found 5 emerging themes come out of all of this. So first and foremost, that ultimately something's better than nothing. A lot of our patients expressed a lot of gratitude for having access to some form of tertiary care during this time, as opposed to having to sort of either just be stuck in limbo or to have to refer back to their community health setting, which may not have been able to provide the level of care that they needed, hence why they were referred to us. A really big one was expectations. So you can't really see this in our ratings based on how they're presented right now, but we kind of had two waves of participants. In the earlier round of participants were people who were in in-person care when COVID hit, and then in March had to abruptly be discharged and continue their care virtually. And we noticed that their ratings overall were just much lower on their virtual care, whereas the second wave of patients who were admitted to our program and had the understanding that all their care would be virtual tended to rate things a lot higher. So I think that goes to show that expectations play a bit of a part in how people perceive virtual care and what their experience is. The next theme would be accountability. And I think this is something, you know, we can all relate to, whether we're working from home or, you know, trying to take courses and are in school and things like that, that, you know, being isolated at home and trying to participate in things over a screen makes it a lot harder to stay motivated and stay accountable. And that was the same experience for our patients trying to continue to stay engaged in treatment virtually. We had some pragmatics come up, so both some pros and cons. The biggest pro would be just not having to worry about the cost of travel or the time associated with taking, you know, a day or two off to travel all the way down to Vancouver from, let's say, northern BC for your assessment and things like that, or taking, you know, a month or two off work at a time to participate in, let's say, inpatient treatment. So that was the biggest thing, the biggest pro. Con also was just kind of like what I mentioned before, that it's really hard to stay focused in something so intense like this over a screen for, you know, many days at a time, and it can start to be a little bit irritating and tiring, which I think is also very understandable. And the last theme, which was also quite important, was connection. So we had a lot of patients expressing that it was really vital for them to be able to maintain some kind of human connection during this time where so many of us are so isolated, and that also having, you know, the set schedule of virtual care with your appointments and your different sessions created a sense of structure and normalcy in an otherwise pretty tumultuous and unpredictable time for everyone. So looking at all this data that we have, I think the big question is sort of, all right, well, what do we do with this, and where do we go from here, and what can we make of all of this information and this feedback? And I think ultimately what we've learned is that virtual care poses many challenges, but also many benefits. And as the pandemic continues, we hope that as the acceptability of just the way things are right now in our world increases, that acceptability of using virtual care will also increase. So we hope that our ratings will continue to steadily increase with that. But I think that that also tells us that there is a great need for further development in this area of care. And we really need to start focusing and putting some time and effort into conducting research that can really help us understand how to conduct virtual care in all of these different treatment settings we have, you know, whether it be, you know, physical or mental health treatment. And while this information was specifically collected in the context of an eating disorder setting, a tertiary eating disorder setting, not only do I think it's generalizable to the rest of psychiatry, but I think that this feedback, you know, can translate to various fields within the healthcare system. And so I think all this information is something that we can all take into consideration when trying to formulate our different virtual healthcare platforms and the formatting and systems of our care. Yeah, that's pretty much my presentation. Thank you for listening. If you have any questions, you're welcome to either email my supervisor, the principal investigator on this project, Dr. Josie Geller. Her email is at the bottom there, jgeller@providencehealth.bc.ca. Or you can also email myself, my email being afernandez@providencehealth.bc.ca. Thanks.
Thanks, Ivana. I think there's lots of lessons I think to be learned there. So I encourage everyone to follow up and learn more about this particular project. It sounds great. So next up, we have a little bit of a change in the schedule. Moira is going to present next on a poster about patient partner input on research into Northwest BC medical travel. So Moira, please feel free to share your poster. Great, thanks, Moira. We can see it. That's wonderful. You're still muted, though.
Okay, can you hear me now?
I can hear you.
Okay, good. I'd like to acknowledge first that I'm joining from the ancestral and traditional territories of the Wet'suwet'en people. I'm a patient partner on the Northern Patient Travel Improvement Committee, which was established in June of 2019. Our leads are Dr. Denise Jaworski and Dr. David Sohi, and researcher Simran Jawanda. But our committee also has other patient partners, family members, researchers, and healthcare providers. And what we're looking into is the issues that people living in northern British Columbia have to face in order to receive medical care. I don't know why this isn't increasing. Okay. Specialist care is available in the larger centers, but Northern BC, or the Northern Health, is a huge region. And so if you look at this, it's more than half of British Columbia. And there are three main centers of care. So being Fort St. John, Prince George, and Terrace. And this huge area is serviced in those three main centers. Now there are other smaller hospitals, but they don't deal with specialist care. So the reason my husband and I have got involved in this committee is that we have to travel regularly now for medical treatments. Travel can be very difficult because of the distances, the weather, the road conditions. There's patchy or no public transportation, difficult appointment times, appointments that are made with no regard to where you come from, and the cost. So the cost, I'll just give you an example. We have a medical plan, but it pays nothing for transportation or accommodation. So the question we're looking into is, how does these barriers affect the health and the care of people living in our area? In 2018, Greyhound stopped running. Now, Greyhound was a consistent public transportation system. When it stopped, what we were left with was a very patchy, or in some cases, non-existent transportation system. So for an example, for us to go to Terrace for a 1-hour medical appointment, we would have to stay 2 nights if we use the bus system. The objectives of our committee are to examine the patient experience, to see what is working well and what can be done to improve the patient experience, and to communicate this to the health authorities and to the public. Our methods, we've included a scoping literature review, We've had interviews with healthcare providers, patients and caregivers, and patient journey mapping, which is a very in-depth account from a patient of a travel experience for care. The patient partners on our committee have felt very included in the research. And out of our participation, we now have an online survey, which is almost ready for use, where people living in the North can quickly give an overview of their travel experiences for care. And we've also created a guide showing the resources that are available for people in the North needing to travel for care. I'm just going to skip over to here. So what has come from the research that we've done so far? Well, we haven't finished it, but although it's not complete, the informal feedback indicates that this topic, the travel for care, is a great concern to people living in our region. The other thing that's come up from the scoping literature review is that there's minimal research into the impact of this kind of delivery on the people living in rural BC. And people living in rural BC don't think that those people living in the urban centers have any understanding of the problems that we have to encounter. I mean, some of the things we're wondering about is, are people simply not accessing care because they can't get to it for whatever reason, for any of those barriers? I want to acknowledge the significance that I think the patient partners have had on our committee. And this is a quote from Dr. David Sohi. One of the major benefits of patient partner involvement has been a shift in the traditional relationship between patients and healthcare providers to a more constructive partnership. Patients are, of course, more empowered by having a stronger voice, but so are healthcare providers, because we feel a much more meaningful and informed connection with patients. And we have felt that on our committee. Now, I'm just going to go through some of these pictures because these are my pictures. And so this one was our journey in January. And we had gone down the day before and stayed overnight because it was winter. And this is the morning. Later on that day, we went into a skid. We went backwards down the road, on the wrong side of the road, ended up in a snowbank. Now, we were okay, but it was a nerve-wracking experience. And this is not unusual. Like, one of the members of my committee looked at that picture and she said, well, that's nothing compared to some of the conditions we drive in. And that's true. That's true. We have 6 months of winter. So this is a picture I took up in Dease Lake on April 23rd. And it looks beautiful there, but later on in that day, it snowed. And these are some of, this is just sort of an indication. We have very remote, isolated communities with people trying to access care. And you know, what can we do to make this simpler and, you know, a more equitable process for people to receive care from remote areas? I would like to thank the conference for allowing me to present here, but I would also like to add that for a patient partner, this was an incredibly difficult process to go through. I'm not a researcher, I've never done anything like this. And I really strongly suggest that if you want patient partners to contribute, that you come up with a much simpler platform to allow them to speak. Thank you.
Thank you very much, Moira. I think you did a fabulous job, and I think your message, we'll take that to heart and kind of figure out a way to kind of make it easier for everyone to be able to participate in future. But thank you very much for your presentation and your poster, and please feel free to ask questions to Moira directly in the chat, and she will be able to answer them. Okay, so next up we have Jim Mann, and Jim is hopefully going to be able to share his screen with us and his poster, and that's going to be on people with dementia doing action research. So Jim, please feel free to click on the share screen icon at the bottom of the screen and share your poster. Sometimes takes a little while. There we go. It's in screen sharing right now. There we go. Fantastic. Thank you, Jim.
Okay. There's a first time for everything. So my name is Jim Mann, and I'm a patient partner, and I have Alzheimer's. I'm also one of the investigators on this project. With me on the call is one of the other investigators, Deb O'Connor, a UBC-based researcher. So thanks for dropping in to view our poster, and I look forward to having questions later in the hour. Quote, about a year ago, my wife and I were seeing our GP, and he made the comment during our conversation, well, you're losing some of your marbles, but we'll try and keep as many as you can, end quote. For those of us living with a diagnosis of Alzheimer's or other type of dementia, the stigma of dementia is ever present, often felt as soon as you say, I have dementia. Quote, our best friends have said it's too depressing, and they are our best friends for years and years and years. That was so hurtful, but now we're making new, more wonderful friends, end quote. One fellow on Twitter last week illustrated this point very well when he wrote that upon disclosing his diagnosis, he lost all his friends but one. And that is why our project participants, the action group of people with dementia, came to the decision after their discussions to name their primary focus as wanting to flip stigma on its ear. Our project is focused on stigma and dementia to counter persistent problems of stigma and social exclusion for people with dementia. In fact, all action group members recognize stigma and discrimination as a dominant feature of the experience of living with dementia that needed to be flipped on its ear in order that people with dementia could live their lives as full citizens. This participatory action research is being driven by our action group of people with dementia, and I want to highlight that all members have a diagnosis of dementia. There are no care partners involved. Research has shown that people with dementia feel less constrained speaking about their experiences when they are with other people with dementia exclusively. Our first meetings were monthly and face-to-face, but now we meet virtually twice a month. This took some getting used to, as many members had not used this medium before. But with a couple of exceptions, everyone has made the move and successfully adjusted from in-person to Zoom. The move to virtual meetings allowed us to extend action group membership beyond urban and suburban areas to include rural members. Meetings are co-facilitated by Deb and I, and it is members' experiences and perspectives that influence our path forward. Our deliberations have even included examination of stigma through the expression of art, which generated much discussion and varying views and perspectives of stigma. There were some great personal reflections on the impact of stigma, and through the wonders of technology, I'm pleased that all pieces will soon be on virtual display on the Center for Research on Personhood in Dementia's website. Now into our second year, members are examining the creation of a self-advocacy guide that will be practical and helpful to people with dementia, and especially for those who receive a diagnosis of Alzheimer's or other dementia, who will be looking for tips and examples on dealing with stigma and living positively with dementia in their community. Quote, I feel just as equal as the person that lives across the street, or the doctor, or whoever, and I don't ever want to think that I'm not equal, because that would be the beginning of the total end of who I am, end quote. Again, thank you for dropping by, and Deb and I will be available for questions later.
Thank you very much, Jim. It was a great presentation and some very interesting and creative work going on there, which is fabulous. And I hope that you will be able to come back in future and tell us more about the guide and how that's worked for people, because that sounds like something that's very important. So please feel free to ask questions in the chat, and Jim will get back to you and hopefully be able to answer them for you. Okay, we will move on now, and Alicia is next. And Alicia is going to give us a presentation on KidneyLink and KidneyPro, which are two online resources. So Alicia, please.
Thank you. I just need to to get Jim's shop to stop sharing. Oh, thank you.
Yep.
Words are not coming, so that's not good.
That's okay. It's I think it's part of using Zoom. I think it kind of does something to us. So
Yeah,
thank you very much.
for sure. Hi everyone. So my name is Alicia Murdoch, and I am a project manager with the Cancel CKD network. If you don't know about us, we are one of the the CHR SPORE network, so the strategy for patient-oriented research, and our network focuses on chronic kidney disease. So I'm very pleased to be here today representing two of our online tools that were developed by our network, KidneyLink and KidneyPro, that are part of our efforts to enhance patient engagement in the kidney research across Canada. So I'll be presenting on behalf of two working groups that developed these tools, and my co-authors are acknowledged here on the bottom of the slide. And I would just like to acknowledge that both these tools were developed entirely within our network, and so we're very grateful to our colleagues, patient partners, researchers, and clinicians who put in a lot of time and effort in helping us get these out into the public. So this is our poster that was accepted to today's conference, and we're very grateful to the BC Support Unit for accepting our poster and for offering the opportunity for me to share it with you today. So I'm just going to walk you through some of the highlights of both of these platforms. So as a network, one of our primary goals is to increase patient involvement in kidney research. Over the course of the network's first years, we identified several barriers to achieving this goal. One was that health research, as you probably all know, comes with its own terminology and processes that can be confusing for those who are not familiar with the healthcare world. And as well, some of these factors can be actual barriers to patients getting involved in research, probably because they don't feel like they understand where they can participate in, and some of them are just deterrents because people think that they can't become involved. Second challenge is that for those who are able and willing to participate, it can be difficult for them to understand and find ways to get involved in the opportunities that do exist and are out there. So to that end, Cancel CKD developed these two tools, KidneyPro and KidneyLink, that aim to break down these barriers and empower patients to cultivate the skills to take part in research and gives them the awareness to know where these opportunities lie. So to that end, the aim of these platforms is to ultimately support Cancel's CKD network mandate to make kidney research more accessible to all Canadians. So the first one I'm going to talk to you about is KidneyLink. KidneyLink is an online platform that's designed to host a wide range of kidney research opportunities across Canada, from clinical trials to focus groups and surveys, opportunities to join a study as a patient partner, as well as notices of like educational events and resources for kidney research. People can visit kidneylink.ca and create an account to see our up-to-date listing of kidney research opportunities and events. And there's also the ability, just right from the main page, for researchers and research staff to upload their opportunities so as to leverage KidneyLink for enhanced recruitment. So when you first log into KidneyLink, this is an example of what you would see, this news feed. We also set filters, so you can filter by category. So if you're specifically looking to be part of a study, or if you just want to do a survey or a focus group, you can search by category. You can also search by topic, which would be like your disease type within kidney research, such as transplant or chronic kidney disease or glomerulonephritis. And then you can also look by study type. So this is an up-close view of one of the opportunities. There is a brief overview of the study. There is information about the time commitment, being whether it's a 20-minute survey or whether they're looking for someone to join for a 6-month focus group or for a 2-year project. There's also contact information, and as you can see, there's a button that says send an email, so that those people can directly email the contact person to express their interest. So another aspect of KidneyLink is our bi-weekly notification emails. Early users that we had tested the platform said they often forgot to go back and check in and log in regularly to see the opportunities. And we realized that it's important not just to build a large user base, but to keep them engaged and coming back to the website to see the latest postings. So we take our most recent postings from that week and we send them out in an email. It looks like this. When people click on it, they get taken to the KidneyLink page where they can view more details, and they can also click on that button to email the person if they're interested. So while KidneyLink is focused on increasing awareness of opportunities to get involved, KidneyPro is a new tool for educating patients and the public about the foundational aspects of health research, but specifically kidney health research in Canada. So this is our online self-directed learning tool that provides an overview of some research terminology, processes, and a variety of roles that can be played by patients throughout the research process, including, crucially, how important it is to support respectful engagement between researchers and Indigenous peoples and communities. It also shares some tips and links for getting involved in research, including a link to join KidneyLink. The goal of KidneyPro is really to equip users to empower patient partners and participants to understand the roles that they can play in research and how to learn how to take a part actively and meaningfully in research studies. So this is just an example of what KidneyPro looks like. The individual chapters are there indexed on the left and can be completed at your own speed in whichever order you prefer. We estimate that the entire module takes about 1 hour to complete, but obviously if you're a fast reader, you can get through it a little bit quicker. At the end of the module, there's a quiz where users can assess their own knowledge and reflect on the lessons of KidneyPro. Users can also download a certificate of completion to signify their participation in the module. As we are a Canada-wide network, we recently launched a French version of KidneyPro, which was greatly assisted by Stephanie Lord-Fontaine, who is the Director of Research at the Kidney Foundation of Canada. So we were very lucky to have her help us get this into a French version so we can start reaching out to some of our Quebec participants that may feel a little less engaged. So these platforms have been, were launched in November 2019, so it's almost been 1 year since they've been live. We have approximately 304 registered users last I checked on KidneyLink, and our analytics show they spend about almost 5 minutes on the site, which suggests authentic engagement with the various posts and opportunities. For KidneyPro, we've had 333 users start the KidneyPro module and begin the training. We are working on an evaluation strategy to better assess the completion rate and attitude changes resulting from this training. We hope to roll that out in the coming months. Evaluation is always one of those tricky things, especially when you're developing your own modules and building it in-house. So we're trying to find a way to make sure that we can understand how we have, not only how many people have taken part, but how many people have changed their ideas and feel empowered now to participate in research because of what they've learned in KidneyPro. So overall, Council of CKD sees these platforms as the promising strategies to increase the volume and depth of patient participation in research across Canada. So our next steps will include raising greater awareness of both these tools to build a larger user base and to undertake rigorous evaluation of their performance to better quantify and express their impact. Obviously, with COVID, it's kind of shut down a lot of our conferences and things that we were hoping to be able to share these platforms with larger audiences. So we're working on trying to find some unique ways to engage people that are currently not, we're currently not reaching. So if anybody has any great thoughts about how our ideas and things that they've done to engage new people during this pandemic, please let me know, because we're always looking to try to reach more people.
Okay, thank you, Alicia. So yeah, please, engagement is always challenging, and especially at the moment. So if anyone has any tips, yes, please feel free to put them in the comments. Thank you very much. We're moving on again now and to Riley. And Riley's poster is on culturally safe patient-reported experience measures. So hopefully Riley will be able to share her screen.
Yeah, great. Thanks, John.
Thank you.
Yeah, thank you. And before I get started, I just want to recognize that I'm talking to all of you today from the traditional unceded and occupied territory of the Musqueam, Tsleil-Waututh, and Squamish peoples. So my name is Riley. I'm a first-year master's student at UBC and the community-based research scholar at the Research and Knowledge Exchange team at FNHA. This is my first conference ever, so I'm really thankful for all of you taking the time to come listen to me speak today. And I'll be discussing FNHA's project, Culturally Safe PREMs, to improve quality of care among Indigenous peoples in BC. So as I'm sure most of you know, patient-reported experience surveys have been undertaken in BC to support health system improvements in a way that puts patients and their families at the center. Yet there's evidence that these surveys are not adequately capturing the voices of all health system users. So there's evidence to suggest that Indigenous peoples are less likely to self-identify as Indigenous on surveys and are also less willing to respond at all. So we propose that this lack of Indigenous participation in these surveys may stem from the surveys themselves. It has been well documented in the literature that adverse experiences such as racism results in a delay or an altogether avoidance in accessing health services. It has been suggested by many that embedding cultural safety, which focuses on addressing power imbalances to create an environment free of racism and discrimination, and also embedding cultural humility, which is a process of continual self-reflection to understand personal and systemic biases, allowing for the development of research relationships built on trust. So embedding both these concepts in the healthcare system will increase Indigenous patients' comfort when accessing healthcare and will increase the likelihood of them accessing healthcare. So FNHA has a mandate to embed cultural safety and humility throughout the health system in BC. So drawing from the evidence suggesting that cultural safety is an issue in the health system and that we need to do something about it, we propose or hypothesize that the dearth of Indigenous experience captured by these measures actually is due to the measures not having been validated using a culturally safe lens. So the project I'm talking about today does not set out to validate these measures using this lens, but it's rather a first step in a larger long-term research agenda that will work towards ensuring that information about Indigenous people's experiences within the healthcare system are collected in a community-driven way and can be translated into action. So we actually haven't started this study yet, so a lot of what I'll be talking about today is what we plan to do. So our first step is we're going to assemble a technical committee of Indigenous experts, patient partners, and other content experts that will guide all aspects of this project to ensure that the research is grounded in cultural safety, and it will include elders, Indigenous patient partners, and service providers. So this project aims to decolonize PREMs, and we'll use a two-eyed seeing approach to do so. So we're going to integrate Western and Indigenous knowledge and methodologies. So there are three components that will allow us to do this. We'll be using a Western scoping review, key informant interviews, and a virtual one-day gathering. So the Western scoping review will search the extant literature in Canada, the US, Australia, and Aotearoa, or New Zealand, for culturally safe and informed ways to measure Indigenous patient experiences. This will be enhanced by the key informant interviews that will probe the knowledge of Indigenous patient partners, elders, knowledge keepers, and health system partners of how to assess patient experience in a culturally safe way that is inclusive of both Indigenous conceptions of wellness and patient experience perspectives. The one-day virtual gathering is planned for the spring of 2021. It's planned to be virtual for now. We'll see what COVID allows us to do. Hopefully we'll be able to do it in person. But this gathering will validate the information gathered in the scoping review and key informant interviews among a broad cross-section of First Nations and Indigenous communities in BC. So this will ensure that the outcomes of this project are culturally safe, relevant, and meaningful to Indigenous peoples of BC, and will guarantee that this work is done in a good way. The results of this project will contribute to the nascent evidence base for culturally safe healthcare experience assessments and research within BC health systems. This is the first step, as I mentioned before, of a larger research agenda that will drive the implementation of cultural safety and humility at the structural, systemic, provider, and interpersonal levels in BC. A plain language summary, community report, and journal publication based on the findings from the review and interviews will be presented to the community at the gathering. And with the prior informed consent of the event's attendees, the de-identified and contextualized findings will be included in the final report. So obviously we haven't collected any data yet. So this is the end of my presentation for this project, but thank you for listening and giving me the chance to speak.
Thank you, Riley. I think for a first presentation, I think you did a fabulous job. I think you laid that out very nicely, and I think the work it sounds very, very interesting, and I hope that we can see some of that develop over the next few years. I'm sure there are lots of questions that people have about this, so please feel free to put them in the chat box. And I would like to thank all of the poster presenters today. I think you all did a wonderful job, and it was very informative and very, very entertaining. So thank you again. The posters are still up on the conference website, so please feel free to go and peruse them all there if you haven't already done so. But now, if you have questions, please feel free to put them in the chat box, and we can continue, maybe even eat some lunch before the 2 o'clock session, 1 o'clock session. Thank you very much.